Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
We're back.
Okay, we're back. Welcome back to Conversations with Christine and Jeff. Quite excited today, but there's a couple things I need to clear up. First of all, there was a wardrobe change today. Thank you very much, Christine.
I am so
Second
impressed.
of all, many of you have not liked my background, and I get it. And I promise for the next podcast or the one after that, there will be a background. I'm sorry to all of you.
Oh, Jeff, we like you just the way you are.
Oh, it's so nice. But the best part about today, and I'm a little scared, is we're talking about RSV. The problem with RSV, and I've been stressing this all week, is I can't say it. So let's try and say it, right? So it's Respiratory Syncytial Virus. Why don't you try, Christine?
Well, I like to add a little bit of a European flair, and I say Respiratory Syncytial Virus.
Respiratory, re-SSPSP, spipatorily, respiratory, syncytial virus.
Respiratory syncytial syncytial virus.
But I think you got it right. I know.
That's so cool.
Let's just call it RSV.
RSV. So we're going to go RSV for the whole time. And it's interesting because when we started talking about this 2, 3, 4 years ago, all we knew about RSV is it caused bronchiolitis in kids. I didn't even really think about it in adults. So what do we have to say?
Well, to be honest, I think that there's still a lot of miscommunication. I certainly remember a year and a half ago, almost every single national newspaper was covering, I think it was during Christmas, and there were families lined up outside of Hospital for Sick Children, CHEO in Ottawa, trying to get in to get care for their coughing children, presumably for RSV, although in the throes of respiratory season, is it COVID? Is it influenza? Hard to say. But yeah, I think those pictures really started the message and ironically preceded the launch of a whole medical discussion about RSV because of new vaccines and new monoclonal antibodies. So overall, I think the term was more readily understood than, let's say, 5 years ago, but it's still confusing, even for the medical community. Point being, it's not just a disease of our wee infants. And I think we need to spend some time talking about that.
We know it's a very common virus, probably a lot more common than we think. We all see it. If you look at the reported incidence, about 7 to 10% per year. So we all get it. We've all had it. And we'll talk specifically about the symptoms. And as you mentioned, I remember that. I remember when they were lining up at all the local hospitals. And we still see that. The vast majority of hospitalizations for RSV are in children, but the vast majority of deaths are in the elderly.
Yeah, I think we're going to include this. I call it the bingo slide as part of our resources showing that, by far, healthcare consumption, hospitalization, by far, is higher in infants under the age of 2. But when you think about mortality and morbidity and longer term complications, we have to think about the, let's call it over 65 cohorts, over 60 cohort. I've even ventured to say possibly a little bit younger for patients with comorbidities, but I think we'll get into that. Yeah, I think the message has to be repeated. It's not just a cold. I remember actually when I was a resident, we were doing our pediatrics rotation. There's no doubt the entire residency group, I think there were 5 of us, contracted RSV. And, we were considered to be a burden to the hospital because we didn't do any work. They had to close down ambulatory clinics because we couldn't physically show up. But I think, in the community, we're not doing point of care testing. So let's talk about symptoms a bit. A patient comes in, it is officially October 1st. I'm pretty sure I've seen a few RSV cases trickle into my clinic already. We don't really know. How do you know, Jeff?
I know, it's funny. And I was thinking about it. My last patient today, I am certain had RSV.
Yeah.
She came in, she had congestion, she's had cough, she had a horrible wheeze. And we talk about the big three. So let's talk about COVID, influenza, RSV. You can wheeze in any of them, and you'll never be 100% sure because we don't do point of care testing. But in fact, you can strongly suspect it. And RSV is a gradual onset, whereas influenza is really fast. They get myalgias, they get fever. So this woman was in her 50s, quite sick, cough, and the wheeze was quite astonishing. And the problem with RSV is we actually don't have any good treatments. And we talk about, apart from mortality, morbidity being greater in those that as they age, the other issue is we bring it home to these children that now get RSV. So vaccinating adults is not only important to protect the adults, it's important to protect the children from the adults. I am certain I got RSV last winter from my little grandchildren, and it was not so pleasant.
But I think, we know a few of our colleagues coin children as unintentional bioterrorists. But I think the opposite happens. And your grandchildren are wonderful. And of course, you want to spend time to them. And we're in fact, heading into holiday season, which coincides with cough and cold season. What a perfect storm. But, I have to say, even though wheezing, sure. There's some places that you're like, I think I'd put my money on RSV. Sometimes I really don't know. And you just sort of send them home and say, rest fluids, etc., if they're healthy. But just thinking about those frail patients that come into my office, patients with comorbid diagnoses, COPD being top of mind, asthma, congestive heart failure. While we're here to talk about RSV, I sort of bundle the discussion. I don't know what your approach is, but...
No, I agree. And we'll talk about NACI guidelines as we go along, but those comorbidities are very important. We think of COPD, asthma, coronary disease, hypertension, diabetes, and I think we'll get into it. But I think what's important is what you said at the beginning. We are entering RSV season. I am now vaccinating for RSV. RSV season is now through March, let's say. RSV occurs all year, but it definitely peaks now. Now's the time. So we want to catch our seniors that are most at risk, the elderly, those with comorbid illness. So now's the time. And this is exactly, Christine, why we chose to do this today, because we wanted to talk to our listeners about RSV at the beginning of RSV season.
And I think, it's important also to emphasize this is a really contagious virus. It is not subtle. And the other thing is that with two subtypes, if you are so lucky or unlucky to contract it earlier, let's say in the RSV season, you somewhat recover, you can get the other subtype in the same season too. So it really is unforgiving. And one thing that I speak about quite often is, we're not so far removed from COVID lockdowns and the inability to enjoy life and spending every holiday yourself, not being able to go on trips to your timeshares. And, time is not a currency we have, it's valuable. So when speaking about immunizations, I focus on that. I focus on long-term outcomes, not just the acute disease. And, what is wellness? What is the risk? And some patients, who are headed on cruises with their kids, that is essential time. And they will try to guard that time and buy an insurance policy to ensure as much as they can that they can get on that cruise ship. So I think that's the silver lining of COVID, and we have to use it.
And the other thing with RSV that we can't forget is we know you don't develop long-term immunity.
Correct.
The elderly that have immunosenescence will probably get 3 months of protection. The young will maybe get 6 months of protection. But RSV does not give you lifelong immunity like chickenpox. So you definitely still want to get vaccinated. And we talked about the main conditions. So, once again, we'll reiterate COPD, asthma, CHF, coronary disease, hypertension. The diabetes, the classic illnesses we worry about with comorbidities. But we touched upon the fact that it's not a benign illness. And although the majority of the hospitalizations are in children, the mortality rate in children is very low. Whereas if you're over 65 and you get hospitalized with RSV, we talk about this number, there's 11% chance that you're dying from RSV within 30 days. That's an astonishing number.
Well, and I think that, we quote that around 8% of people, if you end up surviving your hospital stay, you don't necessarily leave in the same condition that you entered. And 8%, require long-term care. They're dependent on their family. And that concept of not being able to live independently, that's a striking point. People, quite frankly, my patients if I am honest, would say I'd rather die than end up incapacitated and needing to rely on a system or family and not being able to return to my home. So I think that emphasizing wellness long-term is absolutely essential. And the other thing is we speak about high-risk patients. Clearly, they're a target, and bundling the discussion because it's somewhat the same when you're talking about COVID and influenza, the highest risk patients. But even if you're not high risk, they've looked at patients with RSV, and 6 months after a diagnosis, they're still struggling with shortness of breath, with fatigue, etc. Yeah. So, you're healthy until you're not.
Right.
And that's a huge education point. And if you ask any person who's had a vaccine preventable disease and has these long-term ramifications, they go back in time and do anything to try to, maximize their opportunity to avoid those outcomes.
And it's unforgiving. I mean, the chronic complications like the cough, the shortness of breath, they're worse in those that are high risk. So the ones that had, in theory, more severe disease have a higher risk of these chronic long-term complications. And when we talk chronic long-term, we're talking more than 6 months.
Yeah. So I'm going to punt this question to you because you're the cardiometabolic expert. What I have to remind myself is sort of the risk of a cardiovascular event after having RSV or influenza. We talk about herpes zoster. We have some great data about that.
I mean, it's crazy. And we're talking a lot about that now, that the risk of acute cardiac events is very, very high during these illnesses. All three of them that you just mentioned. I mean, I just saw a stat that during hospitalization for RSV in a high-risk individual, the risk of having a cardiac event approaches 1 in 4. I mean, that's an astonishing number. These are not benign, but you know what? As you mentioned, we see that with shingles. We see that with pneumococcal pneumonia. I mean, we see that with a lot of these illnesses. So the point we've made a million times here is it's really not just a cold.
Yeah, absolutely. And I think the way I term it is it's not just a short-term infection. Maybe it's not a fun, let's say 1 to 2 weeks, but talk about those complications that occur relatively soon or could occur, the risk of having an MI. Talk about what happens if you end up in the hospital and what happens if you leave the hospital. So short-term, long-term. And it's hard for people to sort of think ahead. And with a bit of vaccine fatigue in our public, certainly in our medical community, we just need to keep on reminding ourselves that, one of the pillars of what we do is preventative care. And I think vaccines are the main pillar if you're thinking about any other type of intervention that we can do.
All right. So you brought us to vaccines. Let's talk about them.
That was a segue.
All right. So we have 2 now, 2 that are approved, a third one coming. You want to start talking about them? Go ahead and I'll chime in.
Yeah, I mean, I think the main question was, people scratch their head and it's like, is this a new vaccine? Is it a spawn of COVID? No. We've always had it. It's just what's the point of spending time talking about a disease if you can't prevent it, right? But now that's changed, so our conversations can change. And as you mentioned, we have 2 somewhat similar, well, there are nuances, vaccines that are readily available. The third option is an mRNA vaccine, and we don't necessarily know when that's coming for us. So you're just focusing on the 2. Pfizer has a vaccine under the trade name Abrysvo. That was the second to release. And our first option that was released in August 2023, which still seems eons ago, was a vaccine produced by JSK, Arexvy. And I've been vaccinating for the past year and a half, and we have some good data that, in fact, with Arexvy and potentially with Abrysvo, we have 2 years worth of coverage. So I'm reassuring my patients now who were vaccinated last year, as we are in the throes of RSV season, we don't necessarily need a booster. But that's a brief overview. I'll hit it back to you. Let's talk about it.
And that data is impressive. I mean, we've seen, Arexvy came out sooner, so we have data now over 24 months. We know 2 seasons. Thus far, with Abrysvo, we have 16 or 17 months. So it's coming. So we can tell our patients it probably will not be one and done, but it will protect you. And the vaccines are quite similar with nuances. I like how you put that. I agree. Efficacy rates are quite high for both vaccines. we're talking more about the adults, so we won't necessarily get into maternal immunization, but I guess it's worth mentioning because that's a really big nuance and difference between them, right?
Yeah. So, I mean, let's just sort of talk about bird's eye view. So obviously we don't have the ability to compare the vaccines head-to-head. There are no head-to-head trials. The endpoints too and the groups that were studied also differ according to definitions. So I think it's safe to say that to prevent severe disease, and I'm grossly generalizing, but we're hovering around 83 to 85% in general. And then, with extension into year 2, if you look at the most severe disease and the most concerning patients, so patients with comorbidities, as well as patients who are older, there's immense protection.
I mean, over 90% in that group, right?
Yeah. And the main defining factor, in my opinion, too, is RSV is an adjuvanted vaccine, whereas Brisvo is not. I'm not even going to do the generic names. I'm just using brand names.
Right, I agree, because I wouldn't even remember what they were.
We're not even pronouncing RSV.
Forget that.
But the adjuvant in RSV is the same adjuvant that was used in Shingrix. So there's a familiarity with it, and it's actually half the dosage. So, clinically, we were thinking that the reactions would be less, and that's actually proven to be true in my office. I'm not having people come back and sort of shake their fist at me and say, that horrible vaccine. So that's reassuring for both us and patients. And you just pointed out, in terms of a Brisvo, it has a maternal vaccination. So your daughter just delivered a baby.
Yeah, I know.
Right?
You know what? Actually, it's interesting because I was all over it. My daughter was pregnant, 32 weeks. I was going to give her the Brisvo vaccine, and I did. It's indicated between 32 and 36 weeks. So I gave her the vaccine, and then all of a sudden, NACI changed their guidelines, so we'll talk about it. So I don't think my daughter was that impressed, and we'll talk about that. But in fact, I've actively immunized her versus NACI's now suggesting passive immunization with Beyfortus, and we can quickly get into that or not. But that's a significant difference between the two because RSV is not indicated for maternal vaccination. But let's talk about who to vaccinate and NACI.
Yeah. So like everything else in life, guidelines differ, and it's frustrating, I think, for the medical community. So just to be clear, we have Health Canada. Health Canada approves vaccines. And in the case of a Brisvo and RSV, we have approval. If we're thinking, let's focus on the 60 plus population, then we'll get into maternal, for patients over 60. That's Health Canada's stamp of approval, right? And then you have NACI that makes guidelines, for individuals and on a public level. And they don't necessarily match up with Health Canada's quoted monograph stamped approval. So in the case of NACI, they released 2 sets of guidelines with respect to RSV. So in terms of adults, so seniors over 60, they actually recommend that we vaccinate everybody over 75, just an age-based recommendation. And then they have this sort of subtext that for patients between 60 to 74, it's really a clinical decision. So you would think about our higher risk patients with diabetes, COPD, etc. I can tell you that most of my patients over 60 have some sort of diagnosis that puts them at risk. I have a few that don't have an official diagnosis, but before NACI released their guidelines and I had RSV last year, I was actually vaccinating my 60 plus patients with grandchildren, people that were traveling.
I agree.
So, like anything else, you need to know the guidelines. And then there's what we do, the art of medicine in our office. They also recommend seasonal vaccination, which, somewhat makes sense. So you want to optimize the coverage, particularly now because we have 2-year robust data. So now is the time to vaccinate to cover this year and then next year. And in terms of administration, this is where it gets tricky because we're in the throes of respiratory season. There are shots for COVID going into arms. There are shots for influenza. So what they've said is, look, in terms of efficiency, you can co-administer with other seasonal vaccines. But if possible, for non-seasonal vaccines, you have to wait 6 weeks. That's official. Does that happen in my office?
No.
Absolutely not.
No.
Right. So a patient is due for their tetanus or their pneumococcal. And I'm going to have to calendar and start. No. So you just have to counsel appropriately that, the more vaccines one receives, you may have a more robust reaction. And
I tried to avoid not giving two adjuvanted vaccines together, but in fact, the data now says we can, and it's not a problem. I just feel...
Just know your patient, right? I know patients, they're like, I'm not coming back, shoot me up. And then you have your patients that have these reactions that are nervous. Set them up so that they'll come back next year for their other vaccine, right?
So,
Common sense.
We'll quickly review NACI quickly. So they're saying everyone over 75, over 60 is discretionary, especially those at a higher risk. And we gave you the list of higher risk diseases. And as you said, we actually know that over 60% of people over 60% of them have at least one comorbid illness. So like you said, the majority have something. The question comes in, what if I have a perfectly healthy 6-year-old? What would I do? I still think I would offer the vaccination because no one wants to get RSV. Maybe that perfectly healthy 6-year-old has young children or young grandchildren that he wants to protect.
Probably young grandchildren.
It's a really safe vaccine.
Yeah.
And I would certainly offer it. And remember, NACI's looking at the data. NACI's looking at where they're going to get the most bang for their buck. Also, there's a pharmacoeconomic component to NACI, I would imagine. So I think you have to look at the patient in front of you when you make that decision.
And, I think that there's obviously guidelines evolve as evidence evolved. And you looking at other sort of medical bodies. So, the Canadian Thoracic Foundation, Diabetes Association, they're now having a voice to recommend, and not only recommend, but encourage vaccination. And I think that's really exciting when it's not just one body, but multiple voices from credible sources that come forth.
And they're similar, as you said. CDC, Quebec, the multiple guidelines are saying the same thing. And as you mentioned, this should be part now of our respiratory bundle. It should be part of the 5 over 65 that we talk about. We should do that in any case.
And, of course, we have Health Canada, I mentioned, NACI. And then the third column is, what provincially the rollout is for the vaccines and who's covered, who's not. It is ever evolving. Ontario has announced their publicly funded program. It's very niche, but, it saves $1 or $2 for a few patients. And I'm just going to do a brief segue into talk about NACI's recommendations for maternal vaccination versus giving a monoclonal antibody to the baby at birth, because we also have some coverage programs related to that. So since you vaccinated your daughter, which I actually would have done as well, why don't you sort of outline what NACI has said for a bit days?
So I vaccinated her, so I've actively immunized her. We know that the vaccine will protect the baby for 6 months. So it's interesting. You have to look at the timing. So this baby Axel, was born in July. So you wonder, baby Axel's now going to get protection till January. So the baby now has some protection. And one would ask, what if the baby's born in April? Would you do it? I guess maybe a different conversation, but I'd probably do it. So what NACI did is they came out and recommended passive immunization instead of active, using monoclonal antibody like Beyfortus. I'm not sure why. I mean, we've talked about it. I wonder if it's because in the Abrysvo trial, there was a small increased risk of premature birth. And that's why they actually extended it to 32 to 36 as opposed to 28 weeks. Is that you think why they did that?
I think that there's a bit longer duration of coverage with the monoclonal. And logistically, I mean, I from a practical point, because we know that prenatal care happens hither and yon, there's not one touch point. But, for babies, it's easier to get the vaccine in. The question is for babies who are born outside of the RSV season, so they're not in the hospital, but they're approaching RSV season, they're still susceptible. It's complicated with the recall program. So, I mean, we don't really fully know, but I think duration was probably one of the main reasons.
And the monoclonal antibody, nothing, I mean, it's quite efficacious. And as you said, they want us to look back to January the 1st. How are you doing this? I mean, you take care of a lot of babies. What are you doing?
Yeah. So, I mean, right now I can't order anything. So, I mean, I have about 5 babies that were born between January and now. And I'm just going to have to figure out how to recall them. I mean, the reality is, though, is because you're doing well baby checks. And in fact, I'm actually administering a lot of meningitis B. So I don't generally administer those with the others just because it's a fever explosion that parents don't like. So I'm seeing them regularly, and co-administration with the monoclonal Beyfortus will be allowed. But I haven't actually been able to get my hands on the vaccine. But in theory, I'll just have a stock, and that when the baby comes in, I prep the parents accordingly. And then, going for in terms of stock for patients who are imminently delivering, like you, I had a discussion saying, look, this is what NACI says. Can we guarantee that there'll be supply? Will the program be robust? For my patients who are delivering in December, I'm like, let's wait a moment or two because we'll see what the rollout is. But for my patients who are due now or next month, I've generally vaccinated them during their pregnancy. And if you kind of miss the mark and they deliver earlier, they'll get they get the monoclonal, the baby will, because it takes about 2 weeks for immunity to develop. And if they deliver a high risk baby, even in the case where a woman was vaccinated during pregnancy, they'll still be eligible for the monoclonal. So there's a few safety mechanisms that have been put into place, but I think it's safe to say that this season's a bit of a circus, and details need to be ironed out. And again, provincial funding will differ. Although today in the Toronto Star, there was an article about RSV and coverage for our Native patient population, First Nations, Inuit, that's been expanded, which is really exciting. So it is gathering momentum. This RSV story has legs, and I think the public's responding.
I mean, just quickly before we end, we should talk about coverage. The provincial government in Ontario has extended coverage for those in chronic care facilities, seniors' home, retirement homes. So it is covered in Ontario for that group. It's not yet covered for anyone else. I often get asked, do you think it'll be covered? I think it will be, but I don't know anything. And while I'm waiting, I really believe the patient needs to be vaccinated today, not wait for it to be covered next season. So that's really important.
And as well, for public coverage, Ontario and several other provinces have a publicly funded program, as I mentioned, for pregnant patients, as well as infants born during the RSV season with a recall program. So, stay tuned, ever evolving. And, I think the point is that we now have the ability to offer patients protection against a nasty little bugger. That's what I say in my office. And that's really exciting.
Yeah, I agree. And then, as we said, the 3 most common circulating viruses that we're most concerned about now, we worry about influenza, we worry about COVID, we worry about RSV. RSV is one of the big 3. So consider that, especially in your wheezing patients, although that's not 100%. Okay, Christine, that was fun. Thank you very much.
And we'll be very excited to see your interior design skills.
I promise there will be a background out there next time. I promise. Everyone, thank you for joining us, and everyone have a good rest of your day.
Cheers and speak soon.